on this session today. We'll be starting a recording now. So once again, my name is Prashant and I'm honored to be a host for today's event. Kidney diseases is a growing health concern that affects millions of people worldwide. The kidneys play a vital role in maintaining our overall health and well-being, and when they are not functioning properly, it can lead to hosts of serious health problems. Today, we are fortunate to have Dr. Georgy K.Ninan, who will be sharing his knowledge and experience on the latest aspects of kidney disease. I expect that he would be discussing a wide range of topics, including the causes, symptoms, prevention, and how we can take care of our own kidneys. Thank you for joining us today, and I look forward for a productive and engaging discussion. To kickstart the official aspect of the event, I now call upon the President of PPF Kuwait, Dr. Advocate Thomas Stephen, to start the introductory and welcome and in the introductory proceedings. Over to you, Advocate.
Thank you, Prashant. Very good evening to all dear PPF members, friends, and well-wishers. Progressive Professional Forum Kuwait welcomes you to this webinar on kidney diseases. To start with, let me begin with a brief introduction of our association, Progressive Professional Forum Kuwait. It was officially launched in the year 2014. It's a socially responsible collective of professionals to utilize their technical knowledge, thoughts, campaigns, participation, funding, etc. towards inclusive and sustainable societal development. Focusing on knowledge and expertise based on services, PPF takes up various programs such as webinars, discussions, promoting online education platform, project consultations and proposals, scientific programs, and effective interaction with the authorities concerned whenever there is a requirement of such services, and also does necessary charitable activities to help and support the needy. Today's webinar on kidney diseases is organized as part of PPF Kuwait's educational objective. We know the human being in general are reluctant to miseries and enjoys happiness. But the fact is that we are all equal in a distressed situation. A famous quote of Thomas Paine says, "The real man smiles in trouble, gathers strength from distress, and grows brave by reflection." Most of us are familiar with the patients diagnosed with the kidney diseases who are in distress associated with their clinical diagnosis. To overcome the distress, we have to expand our knowledge about the causes of that distress and learn the methods and use the means to mitigate and manage them. Today's webinar on kidney diseases offers a great opportunity to learn from an expert who have extensive experience in the topic being presented. We will be informed about the clinical and preventive aspects of the kidney diseases, and also the mental, relational, and emotional dimensions of living with kidney issues and about other related challenges. I would like to introduce our expert and webinar presenter, Dr. Georgy K.Ninan. Dr. Georgy is a senior consultant in Lakesshore Hospital, Kochi, Kerala. He graduated MBBS in 1975 from Trivandrum Medical College and secured his MD and DM. He is a fellow of the Indian Society of Nephrology and Royal College of Physicians. He popularized early detection of chronic kidney diseases in mid-Kerala, did the first kidney transplantation in mid-Kerala and Kerala's first cadaver transplantation. More than 1,600 kidney transplantations were organized by his team, including cadaver kidney transplantation. More than 35 years of experience in the field of nephrology and renal transplantation. He got a very wide range of experience in clinical nephrology, hypertension, leptospirosis, and critically ill patients with multi-organ dysfunction. He had nephrology training at Postgraduate Institute of Medical Science, Chandigarh. And he established a good maintenance dialysis program in peripheral hospitals using online facilities, actively involved in charity and philanthropic work, and is the president of Kochi Kidney Foundation. He is a member of various national and international societies, and he had organized the 36th National Conference of the Indian Society of Nephrology at Kochi. He was awarded the Fellow of the Indian Society of Nephrology in the prestigious meeting, and he is a Fellow of Royal College, as I remarked earlier. He organized the 6th International Leptospirosis Society meeting in Kochi. He got several publications in national and international journals to his credit and has contributed chapters of renal transplantation in books and many more and more and more. We are proud and very happy to announce that we got the very best and suitable expert to educate us. We are thankful to him for his warm interest shown while inviting him to this webinar. PPF Kuwait proudly welcomes Dr.Georgy K.Ninan to this webinar for his presentation. Mr. Prashant, PPF's Vice President, is the moderator of this webinar, and Dr. Rajesh, PPF Joint Secretary, will be handling the question and answer session. Mrs. Shirley, General Secretary of PPF Kuwait, and Mr. Shankaram, Executive Committee member, are the backend supporters. Once again, I welcome all of you to this webinar, and let's listen to Dr. Georgy K.Ninan and make use of his knowledge and expertise to enlighten ourselves. Thank you, and over to you, Prashant.
Thank you, President. We have Dr. Rajesh, who would be taking your questions that you can ask in the chat window. We have close to about 100 attendees for this webinar, which is quite substantial. And all your questions can be posted on the Q&A directed at the panelists. We have Dr. Rajesh, who would be compiling them and asking and transmitting it to Dr. Georgy over after his presentation is over. Now I invite Dr. Georgy to start his session. I believe you have the screen sharing approval given for you. If you could start your session, yes. Welcome, Dr. Georgy. I request others to go on mute.
Advocate Thomas Stephen, Prashant, Shirley, Shankaram, and Dr. Rajesh. It is very nice to see that Progressive Professional Forum of Kuwait is doing a good job ever since the inception of 2014. And I saw your projection. A lot of work is being done, and that is very important. Dear attendees, also welcome for this meeting. And we'll, without wasting time, we'll go to the screen. And so today's topic is chronic kidney disease. Chronic kidney disease, as you all know, is a increasing problem globally, as well as in India, as well as in Kerala. So today, I'm very happy to share a few aspects of chronic kidney disease, which will be hereafter called as CKD, chronic kidney disease. It is increasing, and so we need to know a few things. First of all, let me introduce the anatomy of the kidney in short. We have got a pair of kidneys, 2 organs, and 150 grams in weight, and 20% of the heart pumping goes into the kidney for purification. As you see, the red tube, that is the artery through which the blood will come inside and will filter and go back through the vein that is blue in color. The filtrate is called the urine, which will come into the bladder and then be peed out. On your right side, you can see the small filter head called the glomeruli, which is the filtering unit. We have around 26 lakhs of nephrons. So today we are restricting our talk to chronic kidney disease. I'm not going to tell about acute, sudden onset kidney problem, chronic, which is coming over a period of few months to years. First of all, we should know whom to suspect CKD. Some of your attendees will be in this group. So we have to identify whom to suspect a chronic kidney disease. That is the first step. If you have diabetes more than 5 years, certainly more than 10 years, you should look for any evidence of CKD. People above the age of 60, because of the less blood supply to the kidney, like in the heart, and more so in people who have cardiac problem, the flow of kidney, the blood in the kidney, blood vessels are less, and therefore they suffer ischemic kidney problem because of less blood supply. If you are a BP patient for a long time, 5 to 10 years, you must anticipate that your kidneys may be involved, mild to moderate degree. And nowadays, with a lot of BP medication, home monitoring with the BP apparatus, electronic, the pressure is better controlled in many. But in few, the uncontrolled blood pressure produces CKD. There was a time when urinary infection, more so in diabetic and females, it was persisting and recurrent urinary infections were there. And these people also suffered kidney infection known as pyelonephritis. Infection going to the kidney, producing scarring and kidney problem. With the advent of newer antibiotics, and now that everybody is tuned to the urinary tract infection, antibiotics are being used widely, and therefore the complications of recurrent urinary infection affecting the kidney is less seen. Stone disease is more, especially in the Middle East, because of poor hydration and high non-veg consumption. The stones are there, same as in Punjab. We have stone belts in Punjab, as well as the Middle East people who are coming. A lot of people come with stones. And stone disease complicating urinary infection, obstruction, and kidney failure. Use of painkillers known as NSAIDs. This is called non-steroidal anti-inflammatory drugs. Example is Brufen, Wolveran, diclofenac sodium. All these drugs are used for toothache, backache, and joint pain. They are not very good. 7% of people who consume this painkillers do develop kidney problem of some sort. And when you have an underlying detected or undetected CKD, chronic kidney disease, use of these drugs will precipitate acute worsening of the kidney problem. Long-term use of the anti-acidity medicine like Pandocid, omeprazole, rabiprazole are also not advised in kidney patients. Many of you may ask, what are the symptoms and signs of chronic kidney disease? Absence of symptom is the symptom in many. We have only 4 symptoms: swelling of the leg, puffiness of the face, blood pressure going higher or becoming refractory to treatment. You may have dysuria, difficulty in passing urine, burning sensation on passing urine. And it depends on the kidney failure, which system is affected. Very often it affects the stomach, intestine, and so many people will have, CKD patients will have nausea, vomiting, and acidity. If it involves the brain, you will have sleeplessness, seizure, fits. If it involves the heart, you will have heart failure because of pressure and uremia, kidney problem producing cardiac failure. So it depends upon which, many often we find that infertility being investigated, the cause is found to be kidney failure and high urea and creatinine. So in short, CKD produces symptoms in the system where it bites. It varies from person to person. How can you detect chronic kidney disease? Urine test is a simple test which anybody can do. Presence of protein, red blood cells, pus cells or white blood cells are suggestive of some inflammation in the filter. These days, microalbumin, small amounts of albumin, we can test for microalbumin, and presence of microalbumin in the absence of regular protein in the urine on routine tests is considered to be the earliest stage at which you can detect CKD in a diabetic patient. Diabetics are the people who are known for producing microalbumin. It is not very specific for diabetic, but in a diabetic, if there is microalbuminuria, then we presume that it is the beginning of the kidney filter involvement. Blood tests can be done. Blood urea, serum creatinine are the two tests routinely done in most of the labs. There are other sophisticated tests, but routine tests are these two. Ultrasound of the scan will tell only structure of the kidney and the bladder and ureter. Any stone, tumor, whether bladder is emptying, all these things can be detected with an ultrasound. So that is why we recommend all these people who are suspected to develop CKD or prone for CKD to do a urine test. Diabetics should do a microalbumin test, blood urea and creatinine, and an ultrasound above the age of 60. Prostate is known to produce some sort of obstruction to the flow, and that can produce inadequate emptying, and the bladder volume after passing urine will be more than 50 ml. Final diagnosis is by biopsy. Biopsy means you have to put a needle into the kidney under ultrasound guidance, take a small tissue out and then examine it, and that will be the final test by which you can diagnose how old is the disease, what is the current problem, what is the future, and what are the medications available now to give for that particular patient or with that particular problem. Urine test abnormalities, coming back to the urine test which I told you before, presence of red blood cells. Up to 4 cells are normal. Many people come to me saying that I have blood in the urine. What should I do? Is there a stone inside? Is it cancer? Up to 4 cells are normal. You must do repeatedly. One single test is not confirmatory. At least 2 or 3 tests should be done on different occasions to confirm consistency of the red blood cells more than 4. Same way, WBC. When bacteria produces WBC, it's called pus cells. Presence of albumin or protein is also a sign of chronic kidney disease. Microalbuminuria is the earliest laboratory marker of diabetic nephropathy, and it is still holding one of the, as the basic earlier test by which you can detect diabetic kidney disease. If you examine the urine, it may show crystals. Presence of crystals will suggest that they may have stones, but they need not have stones. But all stone patients will have crystals in the urine. So by examining the urine microscopy, uric acid crystals, calcium oxalate crystals are all seen in the urine, and you can suspect stones. This is a very important graph. This shows the relationship of serum creatinine to kidney dysfunction. Creatinine is the blood test by which you measure the kidney failure. If you look at your left side, when 100% of your kidneys are working, creatinine is less than 1.4. It will be between 1 and 1.4 in most of us. You see the kidney donor. He is donating one kidney. 50% of his kidney is given to the his recipient, who is receiving the kidney. Even if 50% is removed or 50% of both kidneys are damaged, creatinine does not increase more than 1.4. Once it increases gradually, and that is called chronic kidney failure. So up to 1.4, you have a lot of reserve. And how do you diagnose that? By only, we have measures to calculate, that is all. To find out, estimation can be done, but they are very expensive. Simple way is by this formula. It is available in the net, depends on your body weight, age, and the creatinine. GFR. GFR will be 120 ml when 100% is working, and 5% when the kidney is failing. And this is how we see on an ultrasound. The kidney, which I showed you initially, will be seen as a bean-shaped organ, and stones, obstruction, etc. can be seen. Now, ultrasound is being done routinely and for comparison, prognosis-wise. There is a disease called polycystic kidney disease, inherited disease, which will be manifested above the age of 30, 40. It is nearly 3 to 5% of the population will have this. And polycystic disease is a disease which will spoil the kidneys with their cyst formation. And the cyst will gradually grow, and will finish the kidney off. Stones can be seen in the X-ray. There are two types of stones. The stones which are seen in the X-ray, they are hard, they are calcium stones, calcium oxalate or calcium phosphate. The other one is the uric acid stone, which is not seen in the X-ray. All stones are seen in the scan, ultrasound and CT scan. Nowadays, we do angiograms to identify tumor. Is there any blood supply ischemia to the kidney? Any anomaly to the congenital anomaly to the kidney? This is called a CT angiogram. You inject dye and take multiple cuts, and then you have a 3D reconstruction of it, which you can do. So it is a very useful thing. Also, you can selectively do kidney studies to identify the tumors and all things. There are so many special tests which are, I'm not going into that. They can detect any systemic disease like SLE, joint pain, people who have joint pain and kidney problem. These tests can be used. Renal biopsy is the gold standard to identify the kidney problem, as I told you before. This is a small gun, ultrasound guided gun, through which you shoot. You can see on that gauze piece, two pieces around 1.5 centimeter long, the size of a common pin. This is the biopsy yield, the biopsy specimen. We can subject it for microscopic studies, special staining, immunofluorescence, and electron microscopic studies. Now, when you have chronic kidney disease with urinary abnormality, with normal creatinine or increased creatinine when kidney failure is more than 5%, structural abnormality, then you do a biopsy and diagnose the condition. We divide the kidney problems into 5 stages. Stage 1, whatever be the etiology, this is not detected clinically. You won't know, we won't be able to detect. You will be, the patients are all symptom-free. Stage 2, some people will have frothing, microalbumin may be detected. This is the earliest stage, end of the second stage at which you can detect chronic kidney disease. Most of the people come to us in stage 3 and 4, stage 3, 4, and 5. Stage 3 is when creatinine is borderline, it is slightly increasing, there is frothing of the urine, there is swelling of the extremities, there will be pain in the loin where the kidneys are situated, etc. Stage 4 is the stage at which most of my patients do come. That is a time when they have around only 20 to 25% of kidney function. They want to know what will be my future plan. They will be invariably having high blood pressure on 2 or 3 medication. They are all anemic, means HB is low. They may have bone pain, calcium is low. They may have hypertension as well as unassociated cardiac problem. They may be diabetic. These are all people in the 40s plus 50s to 60s onwards. And stage 5 is a stage kidney problem. You have to consider dialysis and transplantation. And that is a time when creatinine will be above 5 to 8 range. So you have to plan for your replacement and you have to go on with that. Low hemoglobin is a part of the chronic kidney disease. Many patients or many people, when they have low hemoglobin and evaluated for low hemoglobin, the kidney problem is identified. So it is there is a relationship between low hemoglobin and chronic kidney disease. In a diabetic patient, there is a 85% relationship between kidneyopathy or nephropathy and retinopathy, diabetic retinopathy. What is diabetic retinopathy? Retina is the screen on which the light falls at the yellowish at the back of the eye. The light passes through the lens and falls on this. You can see that it is rich in blood vessels. Any diabetic patient having capillary disease or retinopathy will have a bleeding into the small areas of bleeding, as you can see in the 2nd and 3 eyeball at the back. The ophthalmologist will be able to see this with looking into the eye. That is why we always ask diabetic patients who have protein leak, RBC, or any creatinine increase to have an eye checkup by an ophthalmologist to see whether that person has any retinopathy. If they have retinopathy, that means that that person has got nephropathy also. So if you have retinopathy, you must look for kidney problem and vice versa. There is only 85% correlation. There are 10-15% people who may not have one and have only the other, which only on subsequent evaluation we will come to know. How do we treat, having diagnosed that there is a patient with protein leakage, kidney problem, creatinine increase, blood pressure? How do you treat them? It is divided into 2. One is specific treatment, means to the addressing the problem. For that, you need to know the problem. To know the problem, you need to do the biopsy, without which you cannot, and that is a line by itself, which we are not going to discuss today. Most of the people in the early stage will have unidentified kidney problem and they need non-specific treatment. That is where you need to know, and I'm going to emphasize. And so how do we prevent the complications of chronic kidney disease? If we cannot prevent it, how can you reduce the progression of the chronic kidney disease? Most of the chronic kidney disease will progress. There is a sizable 20% of chronic kidney disease where there is a specific cause and specific treatment can be given to that patient, depends upon that disease. So basically, diet plays a fairly big role or moderate to big role in the treatment of chronic kidney disease. Control of blood pressure is very important. We always say that the pressure will be uncontrolled and pressure independently contributes to the worsening of the CKD in addition to the basic disease which is progressing. If it is due to diabetic kidney problem, the blood sugar control is very important. Initially tablet, when the creatinine goes beyond 2.53, insulin is better. What type of insulin? Your doctor will decide. But our bottom line is your sugar should be controlled. Your HbA1c should be 6.5 to 7. Too much control is also not good once a kidney problem comes, because very often you have the patients have no appetite, they don't take food, and they may have vomiting, so they slip into hypoglycemia, low blood sugar. So one should be careful about that and keep some sugar along with you or toffee with you, and that precaution should always be taken. Cholesterol control is very important because we know that cholesterol and thrombosis and calcification and occlusion of the coronaries were there, and the cardiologists keep a close track of that. And 40% of the people with cardiac problems, coronary problems, may have kidney problem to some extent, interfering with less blood supply, producing less blood supply, which is known as ischemia. So these are things which cannot be measured by ultrasound, and only angiogram can tell. And for angio, dye is injuries to kidney. So we have to resort to MR angiogram, MRI, MR angiogram. Uric acid is very important. Uric acid high in the urine can produce stones. Uric acid can produce inflammation of the kidney filter. So uric acid, nephropathy, stones are all there. And avoid unnecessary medicines which are toxic to the kidney. If you go a little more detail into the diet, fluid management is very important. How much urine you are passing, that much fluid you should take. If you take more fluid than that, you will develop swelling of the body. So a steady weight is very important. We advise all our CKD patients to keep a weighing machine and weigh every day. And if the weight increases, that means you are drinking more than the urination, or urination is lesser than with the steady intake what you are doing before. So that should alert, and then you have to look into why the kidney function has deteriorated. Protein content is restricted because protein finally will be converted into urea and creatinine. You can take protein, 0.5 gram of protein per kilogram. That means 60 kilo person can take up to 30 grams. You can refer to net and find out what is 30 gram. But basically 1 egg white, half a glass of milk, and 1 piece of fish, chicken, along with your regular diet will make it 30 grams. Potassium is excreted through the kidney. So when kidney failure occurs, potassium will be accumulated in the blood. In some patients, more potassium will be accumulated because of the inefficiency of the kidney to excrete potassium. Your doctor may be giving some medications which will increase potassium. So potassium is a troublemaker. This potassium will create problem once it goes above 5.5. Normally is 3.5 to 4.5. So once kidney failure comes, potassium should be controlled. And what is the main potassium-rich food? Fruits, coconut water, citrus fruits, all this contain banana, all this contains potassium. Again, you have to go to the net and see what are the food which contains low potassium. You can boil the vegetables and drain the water, which is called leaching, by which potassium can be removed from the vegetables while cooking. Starch is connected with sugar, with a diabetes. If you are a diabetic, you are allowed 1500 or so and continue with that. Too much of starch is not allowed in diabetic patients. But on the other hand, if kidney failure patient not having diabetes, we encourage them to take more carbohydrate because they need calories and to withstand this uremic toxic. Fat in general is not good, but plus minus. Painkillers, as I told you, even a single dose can produce allergic kidney failure in some people. Usually it is a cumulative effect after a few days, reversible. Kidney patients are more prone for that. Other kidney toxic medicines are dye. Kidney is very susceptible for this radio contrast dye. That is the dye they use for CT scan and coronary angiogram. So there are many people with CKD when creatinine is high, then let the cardiologist decide whether it is a life-saving thing, whether intervention is needed. Then you take the risk by hydrating the patient well, use minimum dye, and if creatinine increases, very often they recover with some medication, supportive therapy. Some few dialysis may be needed to tide over the situation. So heart is more important than the kidney. That cardiologist has to decide, and we will give the support to them. That is our attitude. and preferably avoid this. Long-term use of PPI. PPI means pan-dosage-like medications are not good in kidney patients. And as the creatinine increases, then finally there is still hope by doing dialysis. There are many people who have been doing dialysis for 10 years, 20 years. Now the quality of dialysis has improved in many centers. And so up to age of 95, I have dialyzed people. He had been going on dialysis for 20, 25 years. Good quality of dialysis gives a lot of longevity. We have to readjust and readapt to the new situation of a regular dialysis and get used to that life. And then there are some people who enjoy, they come with good food, they enjoy, they share with other people, is something like that. And this is a part of their process till they die or till they go for a transplant. Peritoneal dialysis has limitation. There is a type of dialysis where you use abdominal cavity and then use fluid and exchange, and peritoneal dialysis can be done. But in Kerala, it's not very popular. Now, government hospitals, they are doing because it is in the ECHS scheme or so. Vaccination is very important, not only for CKD patients, those who are listening. You might have all have had corona, this COVID vaccination, 2+1 booster. Now, think you must take a flu vaccination. Flu vaccination is given every year, once a year. And now around 3 or 5 strains of virus can be prevented by this flu vaccine. Pneumonia can be prevented by pneumococcal vaccine. Chickenpox, many of us would have got it. If you have not got it, it is a preventable condition by vaccination. We always advise those who are going for transplantation to get all this vaccination, those who are on dialysis. Hepatitis B now is not a problem. It was a problem. It is not a problem. Many units are hepatitis B and C free. Previously, C was a problem in some of the institutions and Gulf countries. They are very often who is coming back, they were coming with hepatitis C positive, and then they will infect all the people in the, most of the people in the unit. So now with the isolation and good screening, and C is almost gone, B is not there in many of our units. So B is a totally preventable condition. So therefore we advise all CKD patients, not only CKD patients, all healthy people should be vaccinated for flu. They should be protected from chickenpox. Elderly people, senior citizens should be taking pneumococcal vaccine, and hepatitis B is even given to the newborns. Kidney transplantation is the end, it's a replacement. A successful kidney transplantation gives a good quality of life. Many people come here, have transplant, and after 3 months they go back to Gulf, and then they all work there with teleconsultation and with followed by the local nephrologists. Why I showed this, why I'm showing this picture is, it is not like changing the tire. Your old 2 kidneys are retained there, unless there is a tumor or a stone or is it infected. Otherwise, we leave it there. The 2 damaged the kidney, left and right, native kidney, original kidneys are left there. The new kidney is put into the vessel going on to your right leg, above the thigh, in the iliac region, just over the pelvic bone. So you can't feel it on the thigh, it is in the lowermost portion of the abdomen. It is connected to the tube, which is shown here going to the right leg. And second transplantation, we put it on the left side. And third, one of the kidney will have to be removed. As Thomas Stephen said, the opportunity to contribute, my contribution is to associate with 1,600 kidney transplantations in the last 34 years. The first kidney transplantation mid-Kerala, successful transplant was done in Kerala. And cadaver transplantation, 66 cadaver transplantations were done between 2013 and 17. Now Kerala is really struggling to go ahead with, I saw Nobel Gracious name and some of the things about it, but the Soto and Kano is struggling to give people, the kidney, the organs after death. It is happening, but not as much as in this period where we could do a lot in Lakeshore. And then nowadays in Kerala, it is coming down due to various reasons. So last but one slide is that how do you prevent chronic kidney disease? That is what is more applicable for you. That is why I have put it as the last, and I want to emphasize on this. A disciplined life, regular exercise, around 3 liters of fluid so that you pass around 2.400 ml per hour. Don't hold the urine. Nowadays, you have got toilet facilities, good, even in Kerala, so no problem. They're getting better. Otherwise, we always say, KSRTC, go from here to Trivandrum. You have to hold the urine till Trivandrum 4-5 hours. Nowadays, it is changing. Avoid junk food. This junk food and non-veg food culture has really increased the chronic kidney disease. We don't know what is the exact mechanism, the chemicals, or what is the reason, but the chronic kidney disease has increased so much. When I came here, we were only 4 nephrologists 30 years back. Today, there are 220 nephrologists in Kerala. Still, kidney problems are increasing. Periodic evaluation of the chronic kidney disease, or an annual checkup at least is needed, executive checkup, annual checkup. Those high-risk people, any of you are in this audience or your relatives, you should be telling them to do it once a year. Anticipate chronic kidney disease in high-risk patients. Avoid nephrotoxic, allopathic, and other medicines. Don't take anything which once you have any kidney problem, my advice is that nobody is going to save you, including allopathy. All what we can do is to control sugar, control BP, control cholesterol, control uric acid. At the end, dialysis and transplantation. Try to prolong it as much as possible. Avoid unnecessary unknown medicines, which is very, very important. They all contain pure alternative medicines may not contain, but man is becoming greedy. He wants to give relief to the customer by adding steroid, heavy metals, etc. So they are the one who is getting stuck in the kidney filter and producing problem. All diabetic patients should control their blood sugar. They should have a glucometer and take insulin if the creatinine is increased more than 2.53. Otherwise, newer tablets are available, good tablets are available, safer tablets are available. Blood pressure control is very important. Blood pressure is, there are so many blood pressure medications now available, safe ones, cholesterol, diet plus medication. So over the last 30 minutes, what I had been telling you is who are the high-risk patients, and second, what are the symptoms of chronic kidney failure or chronic kidney disease? How can you diagnose it? The need for annual checkup, the relationship of creatinine to your kidney dysfunction. What are the dietary restrictions if you unfortunately develop kidney failure? How to treat them? You identify the problem, make an attempt to identify the basic cause. If you have specific medications available, is fine. I always say justice delayed is justice denied. Treatment delayed is treatment denied. So therefore, an attempt has to be made, and biopsy holds a big role in that. It is a risky thing, but in the safe hands, experienced hands is fairly safe. Then at the end of the, irrespective of the control of, in spite of BP control, sugar control, if he's a diabetic and other control, things may increase, creatinine, urea may increase and go on increasing till you reach the end of the road. That is a end stage renal failure. Then still you should plan for your dialysis. If you're planning only for dialysis, the procedures for preparations for dialysis should be done. If you're planning for a transplant, elective transplant should be done. You identify your doctor, identify the hospital, and then go ahead. Thank you for the patient listening. I'll be only happy to answer the questions. Dr. Rajesh will collect all your questions and will be putting it, I understand, or Prashant, one of them. Thank you very much.
Thank you, Dr. Georgie. I think it was very interesting start to the session. We are only halfway through. I think we have generated lot of interest on the subject, and we have quite a big list of questions that has come on our screen. Dr. Rajesh, over to you now to please take over the proceedings of the Q&A session.
Thank you, Mr. Prasad. Thank you, Dr. Georgie. We are very happy and honored you are with us today in your busy schedule, and a doctor with so much experience from the beginning of the nephrotic or renal disease management from the you are seeing the all through the evolution from the beginning till today. I'm very happy. We are very happy actually. Doctor, I have almost 60 plus questions already, but I will try to reduce it by combining some of the questions. Basically, we divided questions into different sections. In the first part, I will ask, we have questions regarding the early warning signals of kidney failure. Even though you have spoken it, we are asking it, some of the attendees, they are very keen to ask those questions again. So, Doctor, how to diagnose the problem at the early stage? This question is asked by, and plus, are there tests to identify kidney problems at an early stage, early warning signs of kidney problems? These questions asked by multiple people. Mr. Dilip, Mr. Mahesh, Ms. Shirley, Sheshrajan, and Ms. Jasmine. So these are the first set of questions. How to diagnose the kidney problems at early stage? Are there any tests to identify the problems? And early warning signs of the kidney problems?
Yeah, that's a good question. And as I told you, most of the kidney disease will not have any symptoms or signs. So awareness and anticipation is the key to identification. High-risk patients, those who are supposed to get CKD like diabetic for a long time, pressure for some time, urinary infection, stones, etc., they should have their annual checkup. What are the tests to be done? Urine examination, routine urine examination. If you're a diabetic, microalbuminuria, can ask in the lab. It's not a very expensive test. Then, of course, a urea and creatinine along with your blood sugar or other cholesterol tests you can ask for. And do an ultrasound above the age of 40, 45. Because ultrasound gives you unexpected things, see like stones, some tumor, kidney tumor, suspicion of kidney tumor. Then you go for other scans. So an ultrasound and kidney urine examination and blood tests, creatinine, urea. This is a bare minimum. Microalbumin also. This is the answer. Okay, Rajesh?
Yeah, thank you, sir. Mr. Rennie John and Mr. Marshall, they asked what is the first warning sign for a normal man?
So you must realize that even if a donor gives away one kidney, nothing happens. If you run without a stepney, how will you know whether a stepney has air or get in that or not? So like that, God has given us a lot of reserve. So that is why one kidney, it is safe to donate. So even if two kidneys are 50% damaged, there is no symptom. Unless you look for it, you won't see. But once creatinine goes up, symptom will come. That depends on which system that creatinine is affecting. Many people come with gastrointestinal, swelling, blood pressure high, headache, and when they check, BP is high. Some people come with less vision, and then when you check, the eye doctor will find his blood pressure is very high. So this is the symptom. There is no first or a particular symptom. It varies from person to person. So best is to look for it.
Thank you, sir. Mr. Alaf Jacob, he has a question that if a person with a family history of kidney disorder, at what frequency he has to check, considering his family history, especially if he's above 50?
It depends upon, Rajan, that's a good question. As I told you, polycystic kidney disease manifests at the age of 30. So if your parents or sibling, brothers and sisters has been diagnosed as polycystic, above the age of 30 is the time to diagnose with ultrasound.
Mr. Alex Jacob has another question also. He's asking whether there is any concern or any precaution regarding the exercise of kidney, concerning the kidney health.
Yeah. Let me complete the first question. There is a family history. Many kidney diseases are not hereditary. There are few hereditary diseases. But in diabetes, if any of the family member has had diabetic kidney disease, then you also stand a good chance of developing kidney problem due to diabetes. Now, the second question, what you asked, food, exercise, and other habits, right? Isn't it?
Yes,
Rajesh?
yes.
In general, food means avoid non-veg. Much you can have non-veg, but don't indulge in taking too much. Once you have kidney problem, your protein intake has to be restricted to 0.5 gram per kilogram body weight. That means 60 kg person can take 30 gram protein. And exercise is a good thing. Walking, swimming, cycling, they are all good. Habits means no smoking. Give up smoking. Okay?
Okay, sir. Any problem with the over exercise? Because people has the habit of going to the gymnasium and working out 2.5 hours, 3 hours.
Exercise is good. Standard exercise is equivalent to walking 4 kilometers in 1 hour. If you indulge in very severe exercise, the muscle can liberate certain enzymes and that can produce kidney failure. This is seen in patients who run a lot, the vigorous exercises when they take, their muscle enzyme increases, they come with very severe muscle pain and temporary kidney failure. So best is to do medium, not very strenuous exercise, isometric exercise like walking, swimming, cycling, etc. Gym you can do, but not very vigorous one. Vigorous one raises that problem, but if you have a kidney problem, don't do that. Treadmill, etc. You do reasonable, equivalent to 4 kilometers in 1 hour walk.
Thank you, sir. So can you suggest the food which has to be avoided to prevent kidney stones? This question is asked by Mr. Danish Kumar.
Yes, that's a very interesting point. To answer that question, see, many people or many doctors advise restriction of certain food without knowing what the stone is. So first of all, you have to identify the stone. There are 3-4 types of stones, groups of stones, basically 2. Is the stone seen in the X-ray? Very hard stones, calcium stones, Punjab people stones are all calcium-based stones. They, whatever diet it will not go. Still, calcium-based diet can restrict calcium, phosphorus, oxalate. As and when you pass a stone or take a stone, please collect that stone and give it for stone analysis. That will give you a direct information about what stone you have. The other stone is very interesting, uric acid stone. They are the stones detected in ultrasound, CT, but not seen in the X-ray, and they are amenable to treatment. Non-vegetarian food reduction. There are medications like febuxostat or uric acid reducing diet and medications with which you can control this diet. But remember, once you are a stone former, once you have a stone, always you are a stone former. And in the coming years, the stones will multiply, it will grow, it will divide, and then new stones will come. So it becomes a big nuisance. So best is to identify, answer to your question is, identify what type of a stone with stone analysis, urine analysis, X-ray wise, and come to a conclusion. And then depends on the calcium or uric acid, treatment is different, diet restrictions are different. Okay, Rajesh?
Thank you, sir. Thank you so much. So there was one more question. This is regarding the common medication, because this is important, especially in a Gulf scenario, because people have less access to the government hospitals due to their work schedule. So people has the habit to take medications from over the counter. So common medicines that damage the kidney, they are mainly intending, I think, fever and something, pain medications.
Yeah, the first one is the painkiller. Painkillers for aches and pains, dental surgeons, orthopedicians, and rheumatologists, physicians, they all give non-steroidal anti-inflammatory medication. Those who have a kidney problem, they will have worsening of the kidney problem. But good point is that it's a reversible. If you identify and stop it, it will come back. They will have puffiness of the face, they'll have albumin in the urine, herbicis in the urine. So first and most common is the painkillers. Brufen, Bovaran, diclofenac, Meftal. So many drugs are there, 8 or 9 varieties are there. Second common drug is the dye. These days, CT scan is done left and right with contrast. Coronary angiogram is done. But coronary, at least there is a need. When you come with a chest pain, you don't look at the kidneys, you save the patient. And so that is the second drug. Then of course, third is some of the antibiotic. Nowadays, we have got safe, newer antibiotics. We don't use amikacin and all like in the past. Amikacin, gentamicin, all were used, you may remember, after 10, 15 years back, or any urinary infection, amikacin. Yeah?
By the way, you're telling about the CT with the contrast. I'm working in an orthopedic hospital. We have a lot of cases suspicious of pulmonary embolism and doing this CT contrast. And I'm seeing at least 30% of the people developing kidney problems. At least 5 to 10% developing dialysis.
And the good point is that they are reversible. In 2 weeks' time, they will come out. How much support you will need in this acute phase 2 weeks' time is.
So another question from Ms. Jasmine. She's asking, she's taking vitamin D weekly.
Good. But then you look at the.
Hello.
Yes.
So next question from Ms. Jasmine. She is asking about vitamin D intake. She's taking vitamin D weekly. Does this affect the kidney?
In kidney failure, vitamin D is less. But what they need is the regular vitamin D has to be converted into the active vitamin D, and that is in the kidney. So kidney failure is associated with less vitamin D. So you can take regular vitamin D3, the 60,000 unit once in 2 weeks or once a week, no problem. But then that will not suffice. That will not suffice. You have low calcium or bone density is low. You need to take active vitamin D3. Here we use it as, we call it as calcitriol. In your place in Gulf, it is 1-alpha Leo and all. So vitamin D is safe in kidney problem. Most of the kidney patients have less vitamin D.
Actually, here generally population working in the hospitals, hospital field and office, they are routinely checking vitamin D, and at least 95% people, their level is less than normal. So here there's a habit to take vitamin D weekly. This has any,
No
this
problem.
will have any, no problems. Thank you, sir. Thank you.
No.
Another question from Mr. Pramod. He's asking about the effect of BP medicines. And he's asking about the kidney-friendly lifestyle. BP medicine, I don't know.
Can you please repeat that?
Mr. Pramod, he has asked the effect of BP medicines, but he did not give the name of the medicines he is using. He just asked the
Okay.
effect of BP
Once you
medicines.
have got, once you have blood pressure, BP medications are good. Each medications have got side effect, but it has nothing to do with the kidney except for one. That is the ARB medicine. That is losartan, telmisartan like medicine. It has got dual purpose, dual action, not purpose, action. These certain medications like losartan, telmisartan, olmesartan, these are the medications used for BP and for reducing proteinuria. But in some patients, it produces high potassium and worsening of the kidney failure. This is in patients who have got ischemic kidney problem. So if creatinine is increasing while on this BP medication, it should be with that. But in general, BP is a part of the kidney problem and control of BP is needed. So you use multiple drugs rather than one drug, the full use, so that the side effect of each drug will be very minimal, if at all. Okay?
Okay, sir. Thank you. Sir, Mr. Anoop Hakim has asked, there is any medicine to reverse the CKD? And he is asking about a specific product. Its name is Netil, N-E-T-T-L. Does Netil help in reversing the CKD?
To answer your question, Anoop Hakim, there are certain medications which can reverse the kidney problem. For that, you have to identify the kidney disease by a biopsy, and you have to treat them vigorously with corticosteroid, immunosuppressive medication, so that the kidney problem, whatever be the cause of the CKD, will reverse. Second, diabetic kidney disease at a very early stage, microalbuminuria level, this starting with one of the losartan or telmisartan can reduce microalbuminuria or prevent the progression. I did not get the name of the medication you said, nor I am familiar with that, so I am unable to answer the particular medicine which you referred to, right? You have
Yes,
to
sir.
check
Thank
into
you.
the name.
Thank you, sir. Thank you. Another question, if drinking Kochi bottled water and reverse osmosis RO water is not healthy,
it is healthy. See, the bottled water is nothing but an mineral water is an RO water. So as long as that is done under the control circumstances, RO water, there is no reason to think that is bad.
actually, yeah. Actually, sir, the people referring, particularly in Kuwait, there are some companies which is I don't want to mention their name.
I'm not familiar
but
with those.
Yeah, they are checking TDS is low TDS and pH is less than 6. So such water is usually in home supply, like as an RO water. Whether this is healthy or will this cause any problem, that is their concern. I think mostly this may be their concern. This low TDS water is the main water available in home fixation.
So you have to check with the local authorities what is the stipulations and whether they are satisfactory and how safe it is. I am not well versed with that part of the water quality, right?
Yeah. Okay, sir. Yeah. Another question from Mr. Rennie John. He is asking about drinking tea and coffee. Will it adversely affect the kidney?
Yeah. Tea and coffee will not affect kidney problem unless you have stones. If you have oxalate stones, coffee, tea is known to worsen